This is Jerry. We're back. And I'm going to show you, Don said he doesn't mind if he shows his face, so we're just going to go with his face here. This is Don laying on his back. We mobilize that rib, and you're going to see how red he is. It's not that I use a lot of force. I sustained pressure on that rib for about 5 minutes. And earlier when I tested him, I crossed over. My fingers are beneath the ear, found the occiput which curves under, and then right below the occiput I blocked the first and the second vertebrae to keep them from moving. And then I come and I capture his forehead and I make sure I'm locked up with my fingers. I've taken out any motion there, and now his head will only rotate 3 to 5 degrees, and I can't force it to go any further because that motion is happening in that occipito-atlantal joint, and this motion is now restored. Okay, and then here's side bending. There's a little bit more side bending in him, in his joint. Before that, it was blocked. What I was saying is the range seems greater in side bending than in rotation. That was my point. So if you align your stomach, we'll show them about the rib. Again, I didn't treat his cervical spine directly because the upper cervical spine was restricted in response to this rib being stuck. And you can still see a little bit of redness here where I was working. Let's change that camera view. So you can see a little bit of redness right here. And because the rib is a curved structure, when that rib had pulled out and stayed stuck, it looked like it was lower. But when I tested superior glide, it didn't lack that motion. So it wasn't what we would call a rotational fixation on the long axis. Okay, it wasn't that kind of a pattern. It was a rib that moved within normal physiological motion that happens when you twist, in which the rib came this way, but somehow he overloaded his body, and the rib stayed there while the rest of his spine then derotated, and so the rib stayed pulled outward. He wasn't really aware of this tightness, so it wasn't symptomatic, and that's the point. It doesn't always have to be painful in order to be dysfunctional. The price he paid for it was being dizzy from a problem in the upper cervical spine, which may have impacted some circulation to the vertebral artery. That's one speculation. But the important thing is that, once again, to reiterate, we treated his upper cervical spine by working far away from it. And if you count joints, he has 7 cervical joints below that, and then 6 thoracic joints, and then the rib joints, 6 rib joints below. So we worked very far away from the expression of the injury. And the concept is always treat the bottom of the injury, treat the foundation. And typically, if there's a rotational fixation in one of the spinal joints or one of the rib joints, typically you're going to find something on the opposite side of the body below that. And it doesn't have to be painful, but if there's a joint restriction there, then there's a compensation. And the same is true of soft tissue injuries. If it was only a muscle problem, he may have tightness or trigger point in this muscle group, and treating it would ease the opposite side further up. And then the other important point is we don't treat things based on how they look. It looked like that rib was inferior. So we could say, well, it was rotated in an inferior bucket handle motion, in which case I would have had to restore glide up here, but we tested it and it was not stuck that way. Second, one could think that it was rotated in a long axis, and that's a pretty serious injury. It's pretty rare at this level of the spine. You do see it higher up, but at this level it's very rare. But we tested that, and in fact the rib had mobility in that direction. It simply looked like it was lower because the rib was pulled laterally, posterolaterally, and because it's a curved structure, that's how it looked. But the true motion loss was that this tubercle did not, that part of the rib did not rotate, glide anteromedially And the treatment was very straightforward. It involved gapping the rib with an anterior force for about a minute to lift that rib off of the two joints that it forms with the vertebrae. And once you gap that, oftentimes it self-corrects because it has ligamentous and muscular tension. But I went ahead and added a anteromedial rotational force, and I did it for a very long time. I'm going to teach him how to keep mobility in this area and encourage him to get some good soft tissue work. In the area, I have an acquaintance here that does some real good neuromuscular therapy. But I'm going to teach him how to keep that motion in that part of his body, and so he won't need to, to see me for this treatment. If he should fail, then he's welcome back anytime, but I want to empower him in treating his neck by treating this. So that is it. Thank you very much.